So today I just wanted to focus our talk a bit on understanding lipids and trying to optimize your overall cardiovascular health. So here's the presentation outline, and I don't have any disclosures, no commercial bias for our presentation today. So current disease trends, contributors to cardiac risk, overview of lipids. Coronary calcium scores might be something that you've heard and have questions about. Role of nutrition and supplements in prevention and hormone replacement therapy. I wasn't quite sure what our, the audience would be today, but a lot of times, like a male, they might need testosterone replacement, or women that are around like the perimenopausal might have hot flashes and are considering therapy, then we'll address those as well. So a little bit of a historical tidbit. Any history buffs in our audience? Oh, yep, several. So I like ancient Egyptian history, but this is basically atherosclerosis is a 4,000-year-old problem. And this study was very interesting. They scanned, I think, about 50 mummies during like that middle area. And they found that 42 of them had actually cardiovascular structures that were intact enough that we can detect plaque. And so you can see along here, all of that white stuff in the middle section there shouldn't be. That means that it's lining along the arteries, some of like the heart structures, and that's outside of the bones. So that was like something that was very interesting, and certainly they didn't have McDonald's, they didn't have Burger King back then, right? So what is going on? And the other thing is that we knew people back then didn't live to what we are today. You know, our average is like 70, 80s in this room, I think at least, right? But they were dying in their 40s. So why are they having this high plaque burden? And one of the hypotheses is that perhaps like inflammatory, like infectious disease, recurrent things that were contributing to that, because their diet certainly was very different compared to ours, and their lifestyle. You know, if you were rich, you'd had chariots and probably people carrying you, but otherwise people had to walk, right? So prevalence of cardiovascular disease, this is like the worldwide numbers. So all across the globe, nowadays with a lot of globalization of our health, it's not infections that is killing people, but it's actually cardiovascular disease. So ischemic heart disease is number one, and stroke is following that. Followed by hypertensive disease, other cardiomyopathies, myocarditis. Those are more heart failure or infections that lead to inflammation of the heart. Rheumatic heart disease has really drastically dropped because of the fact that there's antibiotics and people are more aware. Even in second and third world countries, we know how to treat them and have more resources to help them. In the US, here's like the age standardized cardiovascular disease, ischemic heart disease and stroke death rates. You can see here that overall cardiovascular disease is still very high between male and females, and ischemic heart disease or heart attacks is the one that is most prevalent. So you always hear about modifiable risk factors. So well, what are those? Those are things that you can control, right? We can't control our age, we can't control our gender, can't control our ethnicity, but things that we can is behavioral risk, like dietary. What are we eating? We'll address that towards the end. Smoking, we all know that that adds to cardiac health. High alcohol usage, secondhand smoke, low physical activity. I heard you folks a lot of you are participating at the senior center, so you're doing yoga and tai chi and a lot of different activities, so you're trying to counter that modifiable risk with activity. Environmental or occupational risk, so being in like a high pollution area. We know that cardiovascular disease, arrhythmias, those increase during the winter months, especially in places that have inversion because the air pollution. Household air pollution, lead exposure, temperature changes, metabolic risk. These are more of what when you go to your internist and they're treating for you. So high blood pressure, diabetes, or insulin resistance with that high fasting plasma glucose, high body mass index, abdominal obesity, cholesterol, kidney disease. So this is something that is less discussed, but I think is also very important, is geriatric conditions that affect cardiovascular disease. So if you have a lot of multiple comorbidities, things that, chronic medical illnesses that you have multiple of them, that increases your overall risk. Polypharmacy, having too many medications. A lot of times we go to the doctor, now our foot hurts, now we get a medicine for that, or a back pain, and then that causes side effects, and so now you get another medicine to counter that. Or you just have a lot of different medical issues, and that's why you have a whole pile of different medicines. So polypharmacy we try to limit in geriatric patients. Cognitive decline, vision impairment, hearing impairment, urinary incontinence, functional impairments, sarcopenia like muscle loss, and frailty. And then this is one of the studies that was published in 2025, so very recent, just last year. They basically looked at the different factors in their study and broke down the different prevalence of the different geriatric conditions. So muscle loss was quite prevalent at 70.7, so almost 71%. Frailty is next in line at 66. Cognitive decline, so early dementia, 56%. And just having the fact that you have multiple medical comorbidities, 42, and then it goes down into the other factors. So why is that important is that most people in this population actually have multiple, okay? So the green here is just one condition, 0 to 1 condition. That's only 18%. 19 have 2 of these factors that we talked about. 31% 3 to 4 conditions, and the pink, 32%, have greater than 5 conditions. So as we age, our health declines, and so we actually have a lot of more comorbidities. And you can see, if we're talking about the pie, is that majority of people have multiple things that they're dealing with. At the bottom here, basically it looked at, if you broke down the different conditions, overall major cardiac events, if you had 3 to 5 geriatric conditions, you're at a 1.6 risk. If you have 9 geriatric conditions in here, then you're at a 7.5-fold increase in overall risk. Stroke is similar trends. 3 to 5 is 2.2 versus 9.9, almost 10 for all of the different conditions. Overall death is at 1.5, or with all 9, then it's 4.2. And specifically heart attacks is 1.5 if you have 3 to 5, and if they have all 9 of them, then it's 11 times greater. So as we talk about cardiovascular disease, one of the key things that we always discuss with patients is management of their lipids and why that's important. So what are lipids and why do they matter? So lipids are basically a spherical molecule. It's in our blood. It has a protein core, shell on the outside, and then lipids, including like the cholesterol, the triglycerides, all the different components that don't like water on the inside. Okay, so it has that protective layer so that it can be transported in the blood, and on that it also has different molecules that allow it to interact with cells, like the liver cells, our muscle cells, the lining of our arteries even, and those are basically the signal proteins. We always hear about, and patients ask me all the time, the good versus the bad cholesterol, okay? Everyone familiar with that? Yeah. So why do they have that distinction? Well, the HDL, or the so-called good cholesterol, is a small portion of all the different cholesterols that we worry about in the blood, okay? When you look at your panel and you see HDL, or high density lipoprotein, that's the ones down here. And the reason why we consider the good cholesterol, or anti-atherogenic lipoproteins, is because the reason it's dense is because it basically just has the protein shell. It doesn't have a lot of cholesterol in there. What it does do is that then it travels in our body, it sees where the cholesterols are, it grabs onto it, and it transports it back to the liver to have it processed and properly stored so that you don't have excess in your bloodstream. The rest of them are considered pro-atherogenic lipoproteins, okay? And in those, it's not just LDL or the low density lipoprotein, it has others as well. But because they're in our blood transiently, we don't think of them as like a predominant breakdown. Sometimes if you do like advanced lipid panel that your doctor might order, those are expensive, so it's not going to be what you get routinely, but you'll see like the different breakdowns of them, and that might include very low density lipoproteins. The chylomicrons are the ones that are very even lower, and these are the ones that are high right after you've had a nice meal. And they're transient. They might be in there just like a couple minutes before they start getting processed down into the other subtypes of your lipoproteins. So we never fractionate it separately. And then we get to the LDL, and then people can have large LDL particles, you can have medium size, or you can have small LDL particles. And we make that distinction because with one of the theories that we're going to talk about with the retention hypothesis is that maybe smaller particles, they can seep underneath between the cell gaps and embed cholesterol there much more easily than if you have like large particles. And people have variations in that. So your doctor might check what's called an apolipoprotein B, B as in boy, and that includes all of these guys. Every particle that has the potential to cause cardiovascular disease have one of these ApoB molecules. So it basically is a bit more comprehensive for us to look at and more accurate because of the fact that some people can have varying cholesterol levels simply by the fact that they have maybe a lot more small particles packed in versus maybe they have large ones. Then there's also one that's called lipoprotein A. Have any of you had your doctor checked? Okay, so several of you have had it. Yeah. So the American Heart Association and American College of Cardiology, they put out guidelines and recommend that everyone should be screened at least once. Okay. And we'll talk a little bit more about why this one is important. When you look at a regular lipid panel, how it is that they measure your total cholesterol and they measure your HDL, okay? Then they measure your triglycerides. The LDL is actually not a direct measurement, it's a calculated measurement. So your doctor may say, well, I'm not sure if his calculated is correct, maybe because your triglycerides are too high, for example, or too low. It can affect the calculation. So he will order either a direct LDL, which only looks at this. On your panel though, there is a non-HDL component. And you can look at that as well because that's part of the standard. All it is your total cholesterol minus your HDL, and it gives you that non-HDL. Non-HDL is going to include all of these in there, okay? However, if we have the capability now, so we fractionate it and we say, okay, well, what is the actual ApoB molecules, which is all of these guys in a nice quantified form. And we can also separate that and check just the lipoprotein A as well. If all I want to know is what is your actual atherogenic particles, I can get an ApoB level and you don't need to fast. If I just want to know what your lipoprotein A level is, you don't need to fast. If I want to know what your triglycerides are accurate then you need to fast. Because if you had just a fatty meal, those are going to be very high. Even high carbohydrate meals can also affect those as well. More of that individualized tailored therapy. So one example is that, let's say those subsections is going to show that maybe you have average size LDL particles, or your pattern is that actually you don't have just average, you have a lot of these small LDL particles and you have a lot of them. Okay, but because they're small, they're equal to the guy that has this large LDL. But maybe he only has like 100 molecules versus you having 150. So that extra 50 of having atherogenic particles increases your cardiovascular risk. And that's why having that extra panel can be helpful. Now, that is more in the setting of prevention. If you haven't had cardiovascular disease, we want to try to understand that a little bit further. But if you've already had established stroke or heart disease, having this subfractionated might help you understand why about your own body, but it's actually not going to add necessarily to your therapy, because we've already decided that you need some sort of cholesterol lowering therapy, and doing this extra work might not be helpful. Where I do this is for younger patients or people who haven't had a cardiovascular event. They come in and we're trying to say, okay, well, overall you're active, you're not overweight, you don't have all these other factors, it's just your high cholesterol. Let's subfractionate your cholesterol and see where your risk actually is. Each of these tests has a CPT code. You can say, I have these, I want this test done, how much is it covered? The advanced lipid panel is a little bit more expensive, but I think for the most part, I don't recall in the past when I ordered it more regularly that it had any problems. That one with Quest, it also has like inflammatory markers. It does this breakdown for you. It gives you kind of a profile. It does a nice little summary. And it's a local company, Boston Heart, that does it. So lipoprotein A, as promised, we're going to talk a little bit more about it, is the structure is like on that picture an LDL particle, but it has a little extra tail called the lipoprotein A tail. And there are some differences in terms of race or ethnicity. So African Americans, for example, they have shorter tails, but they have a lot more particles. As opposed to Caucasian counterparts, they're a little bit longer, and so the idea is like it takes longer to produce them, so they don't have as many particles as one possible explanation. But there is some ethnic differences. It has the ApoA, that little tail, and it also has that ApoB, as I mentioned, is that includes all of the particles that can contribute to plaque buildup, hardening of the arteries, has that ApoB. It's genetically determined, and roughly 20% of the population has it. And the levels actually quite vary. From this over here, you can see that these are like the different plasma proteins. You have the green, the yellow, the orange, kind of the pinkish, and then red. And these are the actual concentrations. They're associated with different disease processes, because one is that it is more atherogenic, meaning it's more powerful or sticky, as you will, to the arteries, and can increase our cardiovascular risk, which is stroke, heart attacks. It's also been associated with aortic valve stenosis, or thickening of the aortic valve. That's the valve that's the last door before blood exits. As we age, we will also have calcium buildup on our valves as well, but having high Lp(a) could be one of the risk factors. Pro-inflammatory, and that might be one of the reasons why our valves thicken, and as well as like our arteries are more likely to harden and build up plaque as well. And they're prothrombotic, meaning that it can be associated with blood clots, which also factors in with cardiovascular disease. So as the concentrations increase, you can see that there is an associated increase in the actual risk of the development of the different conditions, including heart failure. But this heart failure is most likely also related to the fact that people are having more cardiovascular disease, like, you know, they had a heart attack, so their heart was damaged, and then they develop heart failure, for example. It doesn't differentiate between those groups versus the people who have what are called like the diastolic, where you have stiffening of the heart and there's a decrease in the ability to relax and pump effectively. We think that it's actually genetically determined. There's an actual gene that these people carry that makes them produce more of these lipoprotein A type particles, and you inherit it through, and a lot of times families, like your brother will have, let's say, a lot of, oftentimes it's, oh, well, my sister just had it checked, so then other patients will come in and want it checked, so we check in and it's high. So it tends to run in families. That's what I mean more by 20% genetic. We don't have treatment for lipoprotein A specifically currently, so the treatment is going to relatively be the same, with the caveat that you have to evaluate the person's individual risk. Okay, some people, if they're, especially like my 20, 30-year-olds, they come in, they haven't developed all of the other risk factors, but perhaps they only have this elevated lipoprotein A, and it could be 100, it could be 400, it could be 600, right? So based off of that, I would have to tell them, I say, what's your family history like? If they tell me their family history is like, well, you know, dad had a heart attack when he was 50, grandpa had one, you know, my uncle had one, he or she is in a different category than a person said, oh, everybody's lived to like 90s, my dad's 75, no cardiovascular issues, they did have their check, but then it was a little bit high. That's a very different story and scenario. So treatments, if we do medications right now, it's pretty much going to be the same because we don't have something targeted towards it, but where everybody needs treatment is up for question. So basically what they did was that it can be measured in nanomoles per liters or milligrams per deciliter. So this one is more accurate because it's like a concentration, where this one is just the total mass, and so it's a little bit less accurate. But depending on the lab that you use, it can have varying numbers. So basically you need to be mindful when you're interpreting your data if they're looking at nanomoles versus milligrams, because you can see the milligrams, it's greater than 100 is considered the highest, but in nanomoles, you know, it's 200. If we look at this, is that, you know, towards this side, is it a higher propensity for that? So for heart failure, for example. So each of these different conditions, remember, this is not individual, it's population based, right? So this is per 10,000 person years, the risk, okay? So it's not individual, and it does not necessarily mean that just because you have a high Lp(a), you're gonna get all of these, okay? The idea is that we see a signal that increases the individual risk. So you can see that overall, aortic valve stenosis, the absolute risk is less compared to, you know, heart disease or heart failure. Here you have, but then we do see the fact that if you have increasing, you know, between the different bars, the green is low level versus the red being the higher percentiles, then that risk increases, okay? And then the same for ischemic stroke. This one is kind of interesting, as you can see that in strokes, maybe it's just having the fact that you have high Lp(a) is already enough, and it's not necessarily divided by the different quartiles of the levels, okay? And we definitely do see that. In heart disease, I can have a person with, you know, kind of lower Lp(a), and they've already had their heart attack. And then I have patients that come in and their numbers are like 500, 600, and they haven't had their cardiovascular event. And we're sitting on their absolute numbers being anxious. So it's not absolute. There's going to be environmental factors as well as other genetic factors that are going to interplay into that person's risk. And then the same for heart attacks. This one's a bit more linear, and then heart failure kind of follows that trend. So one of the questions I get asked is that, Doc, you haven't really convinced me that having high lipids causes cardiovascular disease, okay? This study is nice. It's from 2017, and it looked at all of the different trials that were ever done on lipid management, and what they saw was that there included 200 lipid studies. There were over about 2 million participants in these studies, cumulative, and that equated to 20 million person years, okay? And the key thing is that of all the different trials, you see that here's the magnitude of exposure to LDL cholesterol. This is in millimoles per liter, so it's a little bit different compared to what we see in milligrams per deciliter on our panels in the US. This is more like used by Europeans. And then proportion to reduction in cardiovascular disease. So the idea is that you can see anything that is lower, we have less cardiovascular disease. If it's higher, then you see more cardiovascular disease. So this is basically evidence that one of the factors that increases heart disease or strokes or cardiovascular in general is this higher LDL burden or these bad lipids. And you can see that the mean follow-up was 52 years, so half a century of data. And one of the explanations for this is called the retention hypothesis. These images here are of the carotid arteries. So in A, there's a little bit of thickening, and then B, you can see that there's a little bit of plaque kind of thickening there. C, you see more of it. It's starting to bulge a bit into the artery. Here, there's a lot of it, and here, it ruptured, and it basically is occluding most of the lumen of the artery. So when you were in utero, this is where, and we were first born, but look at this. In childhood, we think that the process already starts. And now when we have a lot more childhood obesity, our children are having high cholesterol as well as diabetes, we're going to see more of this heart disease burden as they get into their adulthood. Here into adulthood is where we already have signs of plaque buildup. And as we continue into our older years, then it can obstruct, the plaque can break off and form like a thrombus, which basically our arteries are saying, it's like a zit. It opens up, all that stuff spills out into the bloodstream, the body says, oh, there's an injury, I'm gonna go and try to repair it, and it forms a blood clot and it cuts off the total blood supply. There is some evidence that it reverses itself, and that data actually came out of programs that are certified for intensive cardiac rehab. They looked at it in people who already had cardiovascular events, and one of the requirements in order to qualify between a regular cardiac rehab program and intensive is that you had to prove that you can reverse disease. And it's pretty comprehensive. They tackle, all that life simple aids, the sleep, the stress, the cholesterol, blood pressure, diabetes, all of that. And what they did find was that some people had repeat stress testing that showed normalization. Others, they actually did a repeat angiogram and showed that there was plaque regression in the areas. So if it's more of this soft plaque, some of this can regress and or it stabilizes into more of like a hardened material that is less likely to rupture like a zit. It's like more of like the dry one and that just stays there unless you pick at it versus something that is more unstable. For general population, the newest guidelines that came out that was presented at ACC just this year, a couple weeks ago, is that for overall primary prevention, LDL should be less than 100. For people who are at higher risk, maybe they have other metabolic disease, blood pressure, and that should be around 70. And for people who are high risk, maybe they've had premature heart disease, is about 50. And in Europe, they do 55. So we have a lot of different kind of tools we use to try to predict person A from person B, lady A versus lady B. But it's not perfect, and one of them that your doctors may use is the pooled cohort equation that was based out of some of the studies from Framingham, so not far from here. Or there was a newer one that was released about 10 years ago called the PREVENT, and that incorporates more of our metabolic diseases like chronic kidney disease, for example, into there. But what they found in this study was that there was like a significant prevalence of non-zero coronary artery calcium. And my next slide will talk about what coronary calcium is. And that was observed in low-risk patients. It was about 45% for the pooled cohort and 51% in that PREVENT group. So when you go to your primary, they may say, okay, well, your cholesterol's high. I'm going to plug this into these numbers, and you're going to get a percentage that comes out. If it's greater than 7.5%, you're high risk, you're going on meds. If it's less than that, we'll watch and you diet and lifestyle, exercise, or whatnot. This study basically says that's not quite true, because some of these people have already shown evidence of plaque buildup, even though their risk score is actually low. Okay? When you get older, these risk scores can be less predictive, and then when you're very young, that's another kind of blind spot that we have. So here is the coronary calcium, and it is what basically, as the plaque goes through and matures through its life cycle, if it can have partial ruptures and then heals, but it's like think of something like a recurrent injury. You know, it could be a tendon or something. When you injure it enough, or your skin, and it forms like a callus, it turns more into calcium. This is what we're seeing in the arteries as well. It does not have to be an actual cardiac artery calcium score. It can be any CT that you actually have. Maybe you have lung CTs, you have abdominal CTs. We can see these, the evidence of plaque buildup, and when you come and see me for a consult, I actually will look through prior cardiac, any type of CT imaging to look for this. And if I see that you're not on cholesterol medications, I'll say, hey, you know, there's definitely a lot of plaque burden or little, we should consider treatment for you. And it gets broken down to like 1 to 99, greater than 100 is considered more significant plaque burden. By the studies, that's where we start seeing the takeoff with the cardiovascular disease. 300 to 1,000 is very high burden, and greater than 1,000 is very extensive burden. And this is taken, this image on the left here, I'll point it out to you folks. We're going to look along here for this area of like a nice little bright spot that is calcium chunk in one of the blood vessels. So this gentleman he's 74 about, and he basically only has high cholesterol. He doesn't have high blood pressure. He runs, he's lean, he runs like a couple miles a day. He's an executive, he's very healthy otherwise. And his idea was that his primary said, hey, you need to be on cholesterol meds. He's like, I don't really think so. I'm pretty healthy. Do I really need it? So we went ahead and tried to risk stratify him with the coronary calcium score. There's different types. Statins and the different types are going to be first line. They're most powerful. They're easily accessible. All insurance covers them. And overall, they're quite minimal in terms of like their side effects from a safety profile standpoint. There's always going to be people that don't tolerate it, but statins are going to be the first line. Then there's ezetimibe, which is non-statin. There's injectable medications, PCSK9 inhibitors that also target cholesterol. Sometimes people don't tolerate a certain type, but if you re-challenge them with a different one or lower doses, you can make it work, and that might be enough. It's also an individual choice, right? So one thing I mentioned is that a lot of people have already had some sort of CT scan for another reason. You went to the ER for something, you can have that. If you've never had it, then it'd be worthwhile to know. But it depends on your age as well and what your actual risk factors are. If you have enough risk factors already that, let's say your diabetes isn't quite well controlled, you've been a long-standing high blood pressure, for example, your risk starts to add up because you remember those modifiable risk factors we talked about? It's starting to accumulate. So getting the CT scan, is that really going to change your management? Maybe not. And what is the risk to you? Well, this is an out-of-pocket test. It's about $250, $300. Some people, you can afford it easily, other people can't, right? The other thing is that it gives you radiation exposure. I mean, it's not a lot. It's like a couple chest x-rays, like 5-6 chest x-rays. And you're like, well, I really want to know in order for me to understand that I am in this higher risk category. But it depends on your age. Like if you're above 50, I say, okay, that's probably reasonable to say because you've lived long enough. The plaque, if it was there, it's had enough time to settle down, mature, go into this process. But there's going to be a subset of people that don't undergo this calcified process because maybe they don't have that recurrent injury. And I had another gentleman, I do lipid clinic for prevention as well, so I see a lot of these patients. He had like some kind of weird chest pain, and I said, I think you need cholesterol medicines. Same kind of profile, metabolically healthy, never been on any meds his life, ate healthy, ran Mediterranean diet all the way. And I'm like, we're going to get a coronary CTA, which actually looks inside the arteries because he had chest pain and his stress tests have been positive or negative in the past. I'm like, we're going to take a look. His coronary calcium score came back 1. And he had, meaning that it was very low. You know, and he's like also like late 60s, early 70s, so just 1. Like we saw maybe 1 little ditzel. But if you look inside the arteries, he's filled with 30%, 40% the softer gooey plaque that is at risk. So he went on medications. It's not a blood test because we're actually visualizing what we see from like basically calcified bony material. He can have some regression of that soft plaque, because it's soft. It's not that hardened material. If it's hardened, there's no Drano that goes in there. We'd have to go in and clean it out manually by putting in stents, or we have a little rotor blade and then we put in stents. But that is considered like an actual percutaneous intervention for that blood vessel. But it's people who don't quite meet criteria for that. So medicines, one, help decrease the circulation of the lipids. Think of it like, let's say the kitchen sink, right? If you keep washing fatty stuff down into the sink, it's not going to clog today, but 5 years from now, it will clog, right? But let's say you're super careful and I'm going to wipe off all the grease and everything before I wash my dishes, then now it's not going to clog until 10 years from now. So kind of similar concept to that is that if there's excess, you're trying to reduce it down to more normal physiologic levels so that less is there to clog up things. And that's a simplified way to talk about it, but I mentioned, inflammation, chronic diseases of such. For example, dental caries. We never really talk about the dentist, right? We're always talking about the medical doctor trying to fix all of these things. But if you have recurrent dental caries and infection, that is also a risk for cardiovascular disease because it causes inflammation. People who have rheumatoid arthritis have higher risk as well because of that chronic inflammation, bowel disease, all of those. So let's take a look at the CT. And as we come down, you're going to see here, this is the pulmonary arteries, this is the aorta. We're starting to seeing the heart. This here is where the arteries start to split. Oh, yeah, missed it. Let me go play it again for you. Okay. So you see that bright spot right there? So that's calcium that is inside his blood vessel, and that's the LAD, or the widowmaker. But as you see that, it's like, is that, let's say you go and all of you go get your coronary calcium score after this or something, and then you see evidence of a lot of calcified burden. It's not necessary to lose sleep over it. One is that you don't have symptoms. It was a screening test. If we never got it, you wouldn't know and wouldn't have lose sleep. You might wait for a couple months maybe to get into like a cardiologist's office, but you're watching for signs and symptoms. You're working with your doctor to try to optimize your overall risk. Now, certainly if you have chest discomfort or short of breath or your stamina has dropped off and you have this, then your primary can order you like a stress test, for example, to see functionally is there any like blockages or problems there. But how I analogy this is like, think of like something that's very hard and I'm trying to squeeze it and it's not spilling, but versus like the jelly donut, it's soft and it has the potential to like break out and get very messy. So this is more stable chronic plaque. That's been there. It's been there for years. It didn't just happen overnight. So lipid lowering therapy. There's a lot of different types. This gentleman here mentioned statins. So statins are here. They prevent cholesterol synthesis. And some people, that's the predominant problem. You give them other meds, they don't really respond quite well, but if you block how they synthesize cholesterol, the liver, it actually lowers it quite well. PCSK9 inhibitors are like the injectable medicines that also decrease cholesterol, and how that works is that it upregulates or it prevents the breakdown of the receptors that grab onto the cholesterol to lower cholesterol in the blood. Then you also have ezetimibe, which is another pill. That one works more in the lining of the gut to prevent you from reabsorbing some of the dietary cholesterol as well as the bile acid cholesterols. So those are kind of the main common ones that we have for cholesterol. So the question is that, is there a too low of a cholesterol that starts affecting like our brain or our liver or other organ function? So you are correct, the brain requires it. All of our cells have cholesterol in that. That's how it keeps it moldable. That's how it forms its interactions with like the other cells. But in the trials that did, like especially with the injectable drugs, they actually got LDLs down into like the 40s range, even lower than that, and they did not see any adverse outcomes. So it tells us that we don't really need a lot of it, it's enough. But most people, we're dealing with a bunch of excess, and so that's why we try to target it. But I have people, like I mentioned, if they're young and they're high risk and they've had events and they're less than 50, I'm keeping their LDL cholesterol in like the 40-50 range, and they're going to live like that for the rest of their life to prevent another event. And then in terms of like different side effects, so people will complain most commonly of muscle aches or pains. Some people will complain of more GI upset, like they're just like their tummy doesn't feel well. Other people have more biomarkers that can change, like your liver, because that's how it processes these medications. Statins is one of them. You know, if from drug metabolism, it's either your liver or your kidneys, or sometimes your stool that's basically excreting your these drugs outside of our system, right? So you can have minor fluctuations in your liver markers, but if it's less than 3 times your upper limits of normal, or there's not like a huge increase in your situation, that's not an indication for stopping the medicine. And some people, because of obesity, other metabolic factors, they also have fatty liver. So you add the medicine on and there can unmask some of these hidden conditions that they have. Specifically for like a side effect profile, like this is most likely more muscle pains. This was a study done in the UK. They had like about 80 patients or so. And what they did was they studied them for a full year. They gave them 3 intervention arms. One was no treatment. So for 3 months, they didn't have to take anything. Then they took a placebo, or they took medicine, which is atorvastatin 40 milligrams daily, okay? And it was randomized. The computer will tell them which bottle to take. They're just labeled. If they're taking something, they don't know if it's the medicine or if it's just a sugar pill, okay? And what they found was that the no treatment group, a lot of them were still, and they logged daily into an app about like what symptoms they had, is that they still have some sort of baseline symptoms. So a lot of it, we think it's the medicines, but it is totally not related. Then here's the placebo versus the statin group, which shows that the bars are very similar in terms of the reporting of the symptoms. So it seemed like it was more a little bit on the psychology of taking a pill rather than that they were actually having symptoms, because we didn't give them a drug. I show this a lot. This is called the Samson trial. A lot of European nations, especially like the UK, are starting to do like sham procedures to make sure that we're actually helping patients. These are one of their drug trials that was nicely well designed, and we really found no difference. And these are people who already had said they had an intolerance. So here's the life essential aids. It used to be 7, but after COVID we realized how important sleep was, because people were getting more sleep, they were in their homes, and we're like, oh, our actually MI numbers seemed to have decreased, and obviously there was some bias in there, like maybe we were missing people who were afraid and didn't come to the hospital as well. But there's sleep, there's nutrition, exercise, glucose control, weight, lipids, blood pressure, and smoking. So if you are able to optimize this, and we're talking about inflammation, it has been shown that it will decrease kind of full body inflammation as well. So nutritional recommendations. Here's a nice summary of like, this one is more kind of like the harmful, the intermediate, questionable data, as well as like the one that we think is beneficial and recommended. When you do a nutritional trial though, it's very hard to standardize for everything. It's reported based off what the patient is eating, and there's a lot of other factors that are going into it, their activity level, and so it's very hard to standardize unless you gave 100 people the same meal every day and then another group another meal to really study that, but we don't do that. So evidence of harm, avoid. So coconut oil, palm oils, those are high in the saturated fatty acids. They raise cholesterol. And those are the things, just think of like, it's solid at room temperature, I should probably avoid it, okay? Eggs have serum cholesterol raising effect. Earlier we had a discussion, one of the staff members was asking me about that. It's like, so the eggs, is it good, is it bad, do we eat it, do we not? The concentration of the cholesterol is in the yolk, and depending on what your diet is like, it's going to affect how much you absorb. Okay, some people are hyper-responders, and it's most likely how they break down their meals. But if you're eating it with like a salad and there's a lot of vegetables and fruits and so forth mixed in there, the absorption probably is going to be less compared to someone that just ate 3 eggs straight up. Okay. Same as your diabetes, any of you are diabetic, they taught you, okay, well, eat your veggies, then your proteins, and then your carbs, and that can help control the glycemic index and how high your blood sugars are spiking. Kind of similar concept when we're talking about cholesterol. Juicing of fruits and vegetables with pulp removal, you're just drinking it straight up, you're not really processing anything, and so that's generally not recommended. And especially, if you eat 1 orange versus that orange going into orange juice into a cup, and now you remove the pulp, you need probably like 3 oranges in order to get that same 1 cup. And now effectively you ate 3 oranges from a sugar content and calorie content. Southern diets also have more of like those fried, soul food that can have a negative impact. The inconclusive evidence would be like the sunflower oil, liquid vegetable oils. Canola is okay. Actually, it has slightly lower saturated fat content compared to olive oil. So there are some of the intensive cardiac rehab diets, they are more proponent by purists. Their dietitians recommend canola, which is nice and cheap, and you don't have to spend the extra money. High-dose antioxidant supplements is unclear. Juicing of the fruits without pulp removal, maybe that's slightly better. Gluten avoidance is only for people who have celiacs or true gluten intolerance. Evidence of benefit, the extra virgin olive oils, the blueberries, strawberries, those are high in antioxidants. The 30 grams of nuts, but if you're dealing with weight, that can add to weight gain. So it has like nice protein as well as good oils, green leafy vegetables, and plant-based proteins. Role of supplements, I think this is like a multi-billion-dollar industry worldwide, okay? And we get kind of sold the fact that supplements are helpful, the multivitamin, and then I'm on ginger extract, then I'm on cranberry extract, like a bunch of things. And the data is actually not very strong for them. And for specifically cardiovascular disease, what I say is that if your doctor finds that you're deficient in something, you have B12 vitamins, folate deficiency, whatnot, then get that treated. You don't have to go out today and base off of this chart and say, well, I'm going to start this supplement, or all that. If you would like, a lot of these can be tested with the blood. If it's normal, then you don't need to supplement extra, and just eating healthy, you're going to get a lot of these micronutrients anyways. And that would be the preferred, because now you get fiber, you're eating less calorie dense foods in there as well that have other benefits. So if we look at this chart, it's a bit small, but like I said, you're more than welcome to access my slides, is that that favors the control and favors the actual supplement. And each of the dots is between whether it's on one side or the other. You can see that most of them are right on the line or just slightly in the positive favoring the supplement. So we look at folic acid. There's some data that helps with stroke. So you can see it crosses over more on like the favors the supplement side. B complex is basically null. Antioxidants, no clear data. Vitamin B3, no clear data. Multivitamins, a little bit maybe leaning towards some benefit, but they're not statistically significant values. We consider it significant if it's less than 0.05, and none of these numbers really are. Here is vitamin D, same thing, it's not significant. Calcium, vitamin C. So really, we really haven't found anything that prevents heart disease with buying extra supplements, okay? Hormone replacement therapy, I'll just quickly mention this here, is like older men, a lot of times your testosterone naturally will drop. You guys go to the doctor, I'm fatigued, I'm losing muscle, should I be on a supplement? The idea is the Traverse trial from 2023 did say that there wasn't an increased risk of heart attacks, prostate cancer, benign prostatic hyperplasia at therapeutic levels, and the key word is therapeutic levels. If people are taking anabolic steroids for muscle building at super therapeutic levels, there is an increased cardiovascular risk. If you are on treatment and your levels are too high, or you're starting to see that your hemoglobin or your hematocrit go up, that means your blood concentrations are going up, that's also an indication to reduce the dose or stop it. For women, I think you're probably in this room or at the cohort that the Women Health Initiative came out, and the question is like, do we treat the menopausal symptoms, the hot flashes, do we not? Just suffer through them, it'll last a year, you'll be fine. The idea is that it's actually safe and it doesn't increase cardiovascular risk. Women Health Initiative, they were in their 60s as opposed to a lot of the other trials that show benefit. The women were in their 50s when they first started. So there's a theory that there's this early treatment group, is that if there were beneficial early hormone replacement therapy, they have vasodilation, increased nitric oxide that dilates the blood vessels, keeps the endothelial or the lining of the arteries nice and healthy, decreasing just inflammatory markers, leading to less progression of atherosclerosis. And that's one of the reasons why when women have estrogen, they present later than men in terms of their cardiovascular disease, because they have that extra protection. So the argument is that if they're early in their menopausal symptoms, then treatment is fine and actually can be helpful for them. If you treat it later when you already have established cardiovascular disease, which the Women Health Initiative was 10 years later on average, then it doesn't show those similar effects. Well, thank you for letting me spend your morning.